Great. Are you happy for me to start? And I think I'll start. Hello, and welcome to the International Longevity Centre's Under the Microscope, Comparing Countries' Experiences of the COVID-19 Pandemic webinar. This webinar is part of our Delivering Prevention in an Ageing World programme, which is made possible by charitable support and grants from Home Instead Senior Care, GSK, Pfizer, Securus, MSD and Gilead. My name's Kate Pierpoint. I'm the head of projects here at ILC. Just very briefly, before I came here, just the beginning of this year, I had 5 years as CEO of Age UK Croydon. So I spent some time in the ageing world, I suppose, if you like, and this is very exciting for me. So thank you all for joining us today. We're delighted to have you all with us for this really timely discussion. We know that COVID-19 has had devastating effects on health systems and economies across the world, but not all countries have fared the same, and there are important lessons for us to take forward when we think more broadly about delivering prevention in an ageing world. So we're joined here by an expert panel of speakers today, including Andrew Little, who is the Minister of Health for New Zealand, Professor Chien Wen-sen, who is Professor in Department of Business Administration at the National Central University in Taiwan, and Professor Itamar Grotto, former Director of Public Health in Israel, who will be joining us a little later. Our panellists will present their country perspectives on how each of their countries have responded to COVID-19 and what we can learn from the pandemic for the prevention agenda going forward. We will also hear from two of my colleagues at ILC, Lily Parsi and Aaron Himawan, about how this work fits into our wider programme of work, along some overarching trends of what we're seeing across the world. We will then also want to hear your views in the Q&A. So before we get started, there are just a few housekeeping rules to go through. So internet issues may affect sound and video, so please do bear with us if this occurs. At the bottom of your screen, you will see a chat function to communicate with panellists and delegates, as well as a Q&A feature where we'll be collecting questions for the panellists. In the interest of time, we would appreciate if you could keep the questions short and focused on the topics of today's webinar. If you are having any issues with audio or video throughout the webinar, try to connect with an Ethernet cable or through a hotspot on your phone. And if you do get disconnected from the webinar, just use the same link from the confirmation email to come back in. You're all invited to post comments on Twitter as well, using our hashtag Delivering Prevention and hashtag Prevention Aging World and at ILC UK. And this webinar will be recorded and published for public access on our website and the YouTube channel. The presentation slides and the recording will be published tomorrow. So do please submit your questions to our speakers using the Q&A feature at the bottom bar of your screen throughout and join in the conversation on Twitter. We will be open up for questions after each presentation and also a little bit at the end. So before I hand over to Lily, just a little bit about the International Longevity Centre. We are the UK's specialist think tank on the impacts of longevity on society and what happens next. We are one of the founding members of the ILC Global Alliance, which is an international network on longevity with members across 16 countries. Thank you. I will pass over now to my colleague Lily.
Thanks, Kate. What I'm going to do really is just give a bit of an overview of what we're doing with our project, Delivering Prevention in an Ageing World, how this fits in and sort of why we're doing this webinar today. So we've been doing work on this area for a couple of years now. And broadly, we know that prevention works, we know it's cost effective, we know it can save lives, and we know that particularly in an ageing world, we're absolutely going to need to move upstream to prevent conditions before they occur if we want to sort of guarantee the future sustainability of our health systems. But it's not just about health. We know that there's big economic costs if we fail to prevent conditions from occurring. So be that productivity loss for people who are working, but sort of much further than that as well. So we know that if we're not in good health, we're much less likely to be spending. We know we're less likely to be volunteering or caring. So it really affects all aspects of life. And, there's a really strong, not just health and sort of moral case, but a really strong economic case for investing in prevention. So we know that case stands. We're not the only people to say this either. And that's sort of why in this stage of our project of delivering prevention, we want to move from this sort of why question to how we can actually make sure it gets implemented, and we move from commitment on prevention to real action. So in this stage of our project, we've been speaking to lots and lots of different organizations, and are keen to be speaking to lots more, including obviously in this webinar today, to find out really what's happening around the world, what has worked well in terms of delivering prevention, what hasn't worked so well, and what we can take forward to make sure that we're sort of moving the needle on this topic. So why are we looking at COVID? We know that COVID has had impacts on sort of all aspects of our lives. It's impacted our health, so directly obviously affecting our society's health. It's had huge impacts on health systems and really brought in this question of how we can make sure that we keep sustainable. And there's a much longer term impact as well on non-COVID related conditions where preventative treatments, screenings, as well as treatments themselves have been put on hold. So we need to absolutely make sure that we're not sort of pausing here, but actually that in the build back, preventative efforts absolutely get doubled up. We know there's been a huge impact on the economy as well. So there's potentially a bigger call for lots of stakeholders to come in and really see how we can act on prevention. And it's impacted all of us as individuals. And while the impact has been global, so no country really has been left untouched, we've also seen that countries have had all different types of responses. And actually, among all the devastation it's caused, we think it's a really important learning point that we look to different countries, what has happened, what has worked well, and what potentially hasn't, to see, on the one hand, how we get better at sort of responding to potential future pandemics, but also which kind of broader lessons we can take forward in terms of how we deliver prevention. So, how we make sure that we're not exacerbating health inequalities and that we're making sure that access is equal, how we make sure that we're inspiring all kinds of people on action in this area. So how do we get policymakers to invest in preventative health interventions and the infrastructure we need to deliver them? How do we get healthcare professionals to really drive forward this agenda and have the time and resources to do it? How do we get individuals to then finally sort of take them up? And I think there might be some really important lessons, for example, from the vaccine program that we've seen sort of rolled out really quickly and at pace throughout the world. And then finally, also looking at something that, again, has come to the forefront a lot during COVID, of how we can really make the most of the potential of tech and make sure it's an enabler as opposed to a barrier. So really excited to hear from everyone today. I'm going to pass over to Aaron, my colleague, who's going to share a bit of what we've seen so far sort of across the world, and then obviously we'll hand over to our panelists.
Thanks, Lily. And good morning, everyone, or good afternoon, evening, wherever you are. So I think what's been quite clear is that there have been varied approaches to responding to the COVID pandemic. But what we've seen so far is that there are several sort of overarching approaches that countries have taken that have really contributed to effective COVID response. And the first one is around this idea of democratizing access, so ensuring that countries are able to protect all communities equally. And one way is by improving access to testing, vaccines, and healthcare services. For example, in China, they've delivered medical testing supplies from remote hospitals to the Chinese Center of Disease Control and Prevention to improve testing rates and to reduce unnecessary human contact to make delivery safer. In the UK, they've been using text messages through an initiative called Test at Work. This was to improve awareness of HIV and access to HIV testing among construction workers who are particularly at risk. The UK has also been able to deliver free transport to those living in rural areas so that they can be vaccinated. And countries across the globe have really pushed this idea of making access to vaccinations really convenient by setting up mobile vaccination centers, particularly in areas where there is poor access or areas which are at greater risk of spread. We also found that supporting at-risk and underserved groups by tailoring health services was really important. In Colombia, in the Guajira Desert, they've been able to support really remote indigenous communities who are particularly vulnerable by enhancing access to primary health care that respects sort of indigenous culture and traditions. In the US, Hmong and Latino communities in rural counties have also been particularly at risk, and they've received consistent messaging in their preferred language about COVID, and local and state organizations have trained community liaisons to answer questions using innovative approaches such as role-playing to model preventative behaviors such as mask wearing or hand washing. In Somalia, they've recently been committed to offering universal health coverage to its population. And this has really been the bedrock for a strong response to COVID since the pandemic. And they've really been pushing over this period for greater access to free health services. Promoting health literacy and population health is also really important approach. And while Israel has been a world leader in terms of vaccinating against COVID, they've also ensured that their population is educated to keep healthy and safe during the pandemic. They focus on health literacy efforts to provide evidence-based information to the public, including encouraging people to adopt behavioral measures for the individual and common good. They've also focused on self-care in pregnancy and breastfeeding, smoking cessation, care for older adults, and physical activity during home quarantine. The next approach taken by countries was to inspire and engage people with prevention. So we know that policymakers all the way to individuals have all play a part in the COVID response. And although at one point it felt as if once we had a COVID vaccine, we would be able to overcome the global health crisis, it soon became quite apparent that we also need to ensure that everyone has access to the vaccine. And so global and national collaboration has been key to that. One example, of course, is the Global COVAX initiative, with more than 2/3 of the world engaged. It meant that over 35 countries have received their first COVID vaccine dose. Also, the speed at which some governments responded to COVID was in part due to lessons learned from past epidemics to infectious diseases. Most governments in East Asia established committees and other coordination mechanisms using a whole of government approach. Taiwan, for example, one of the key factors for Taiwan's success has been establishing a first response task force in January 2020, consisting of experts in infectious disease, public health, and really across the spectrum. In New Zealand as well, they have also taken a whole of government approach, and they've established a border security committee, as well as other sectoral work streams to ensure a coordinated approach, while at the same time having strong leadership to manage that cross collaboration and to ensure that there's sort of a strong institutional structure that's in place and prepared to act. Healthcare integration to alleviate the burden placed on health services was also really important. In LA, they supported an innovative collaboration between 911 emergency medical services and local healthcare leaders to help foster pre-hospital mobile integrated healthcare strategy. This essentially enhanced patient care while also mitigating the impact of COVID-19. And the strategy brought time for hospitals to prepare for patient surge. Supporting and maximizing the role of healthcare professionals was also really important. The NHS volunteer responders involved medical students, pharmacists, and first aiders to be trained as vaccinators. And this also helped to support healthcare professionals and other professionals by carrying out sort of basic tasks such as delivering food and medicines to 1.5 million vulnerable people. Changing the message and the messenger to improve and encourage and improve adherence and uptake of public health measures was also quite key. COVID-19 has exposed racial and ethnic health disparities. And in Canada, they established a South Asian COVID task force, which has essentially pulled together a wide range of partners from religious institutions to schools to community agencies and businesses. And they've really been able to pull together sort of this quite interesting and culturally appropriate messaging using various social media platforms in a wide range of languages. And of course, behavioral economics has a part to play in this as well. In South Korea, those in quarantine were required to self-quarantine using an app for 14 days, and individuals were quite closely monitored by case officers. But at the same time, these case officers supported people's mental health and well-being by checking in on them twice a day. They delivered food, toiletries, they offered psychological counseling and video streaming services for entertainment, and created hotlines and recordings for people, for those who were isolated. During the pandemic, it has been sort of strikingly clear that technology and data has played an important part in enabling countries to coordinate national efforts and safeguard their populations. And one approach is by using big data. And big data has been instrumental in responding to hotspots for infection and disease spread. For example, Denmark, New Zealand, and the US have developed syndromic surveillance, which monitors cases that meet the clinical definition of COVID-19 without confirmation of testing. And by doing so, by sort of implementing this active surveillance approach, these countries have been able to expand surveillance coverage from healthcare settings into communities, and strengthening epidemiological surveillance among particularly vulnerable populations who face barriers and may be less likely to seek healthcare. Also, connecting individuals to preventative healthcare through telehealth technologies has been really important as well. Telehealth, of course, has been widely used across the globe to connect people to their health services. It's really been a lifeline for many during lockdown measures. But most countries, however, do lack the sort of correct regulatory framework to authorize, to integrate and reimburse telemedicine services, including in emergency and outbreak situations. But France has been the first country to reimburse telehealth consultations at a national level to all medical doctors for patients with COVID-19 symptoms and those with COVID throughout the country, even if the doctors did not know their patient beforehand. And we also know that supporting healthcare delivery is of course important alongside the COVID response. And many of the examples I've highlighted do demonstrate the need for a full health and well-being approach to safeguarding people's health. And so in the UK, mental health trusts have been using a digital care assistant to monitor and service users' movement, pulse, and respiration in their bedroom when they're isolated, so that they can provide ongoing health delivery as well as reduce human contact. And then finally, empowering individuals by improving health literacy and addressing barriers to digital health exclusion, again, was quite key. And since the start of the pandemic, local government employees in Greater Manchester have been providing free devices and SIM cards to those who have no devices, as well as Wi-Fi, to help disadvantaged groups to master digital skills. So, you know, there's a wealth of lessons that can be learned from COVID. And I think really moving forward and kind of supporting preventative health efforts is really to catalyze these and learn from these examples, and really see how the global response to improving population health can be taken forward.
Thank you, Lily and Aaron. We're going to move on now to country perspectives from across the world. And we'll start with Andrew Little, the Minister for Health of New Zealand. Andrew Little is currently the Minister of Health and Minister for Treaty of Waitangi negotiations. He has also been appointed as the lead coordinating minister for the government's response to the Royal Commission's report into the terrorist attack on the Christchurch mosques. Also Minister responsible for the New Zealand Security Intelligence Service, as well as Minister responsible for the Government Communications Security Bureau. So Andrew, I don't think we can see you, but we can hear you, so that's the important thing.
Hi, Free. Thanks, Kate. Yes, and it's evening here, so good evening or good morning, good day to all of you. My apologies. I've just been told that there's a security measure on our network here that means that if I'm linked up through a Zoom call to a network it doesn't know, it'll block out the video. So my apologies for that. Look, I'll take us quickly through the New Zealand experience. If we go to the first main slide there, our overall strategy, we determined from the outset would be elimination. And we did that for a number of reasons. We have some vulnerable populations, and we have a health system that is widely dispersed across the country. We feared that if we suffered a major outbreak, there'd be many of our smaller hospitals that simply would not cope. And so we had to bear that in mind. It wasn't about eradicating the virus, but it was about making sure that we could eliminate chains of transmission. And so very early on, we went into our 4-week lockdown. In the period leading up to that, from the Prime Minister, we had very clear communications about what to expect. So about a week beforehand, she did a broadcast one Saturday morning, and it laid out the alert level system that we were operating under. Alert level 1 being the lowest level of response, and alert level 4 constituting a complete lockdown. So within a couple of days, everybody knew what what the risks were, what the threats were, and B, what the responses were to that. And so as the incidence of COVID-19 grew and the number of cases grew, people could reasonably anticipate that we'd get to a point where we would get to a lockdown. And this is, of course, in the context of what's happening around the rest of the world. So what we did from that time too was, like most countries, put controls on the border. We started by preventing travel or entry to the country from a small number of specified countries, and eventually we effectively closed the border. We stepped up our testing capacity through our hospitals and through private contractors so that we could do good surveillance testing, and that when there was an outbreak, we could respond effectively for those who were symptomatic and their close contacts. We promoted and encouraged hygiene measures, so physical distancing, washing of hands, and those sorts of things. And we ran pretty extensive publicity campaigns for all of that. We stepped up our testing capacity. That took some time. It took a bit of effort. We had to get, again, our hospital services and our laboratory services geared up to be able to carry out what for at least our small country was a significant kind of step up in capacity and volume. Our responses included for positive cases and suspected cases was isolation. For suspected cases, if there was a positive test return, then there was a requirement to isolate for 14 days. This is outside of the lockdown periods. And not just the positive cases, but their close contacts as well. And we had publicised what the various forms of contact, close contact and what have you were. And then we legislated for a number of public health measures, health controls, mandated the police to act in certain ways, and various other health officers and so on as well. Our Indigenous community here, the Māori community, they were well organised in many of their communities, and they were supported to take appropriate action to support the more vulnerable in their communities as well. I think I would characterise that period as one where a combination of the Prime Minister's communications and our Director General of Health gave confidence to people that we kind of knew the science, we understood the risks, and we were taking measures. And the messaging was about us all acting together. We talked about the team of 5 million, and I think that resonated with New Zealanders as everybody responded. We had a very good response. We're always nervous in something like this. People do get resistant to government and sceptical about government, but actually we had a very good uptake, and people's response was very good, which helped enormously. If we go to the next slide. In addition to the health measures, we took some economic measures. So we introduced quite a significant wage subsidy scheme. So if you couldn't work, or the business you worked for had to close down, then we provided a high level of subsidy. The objective there was to keep people connected to their work and to their employer. For some industries, hospitality industry in particular, with a lot of smaller employers and tourism industry, it had meant the difference between whether a lot of those businesses would survive. We're seeing that now, that a lot of businesses got through that period, and they did so on the basis of having received the wage subsidy, and our economy has bounced back pretty smartly. There's a reference there in the slide to whanaungatanga. That's the Māori language. Whanaungatanga means relationships, building relationships between each other, and that's how we did it with the team of 5 million. We were very lucky that it was a very mild autumn here when we had our lockdown, and so people were able to get out and do a walk during the day, or do something like that. They couldn't go too far from their homes, but you'd walk around the street, no cars or anything, so people were just walking on the roads and around the streets, and became, although at a distance, a very kind of social sort of exercise. As I said before, we had communicated very clearly 4 alert levels, so people knew what was expected at each alert level in terms of their response, and people bought into that. That was just having simple, clear messaging that people could understand. We had a single source of information, our COVID-19 website, and pretty much everything we could put on there, we put on there. In some cases, the good and the bad, and the good news and the bad news, the science, and anything that we could to feed people's insatiable appetite for information, and that became a crucial part of the information strategy. When I talked about the communications from the Prime Minister and our Director General of Health, Ashley Bloomfield, they pretty much had 1 p.m. every day. They had a broadcast on TV. It was the most watched bit of television for New Zealand for a long time. People pretty much set their watches by that 1 o'clock broadcast to know what the latest was, and that was, and the Prime Minister and the Director General were questioned by journalists. So it was a 45-minute broadcast of messages and of questioning. So people saw that the government was accounting for itself. I might add too, Parliament had to be suspended. We set up a special parliamentary committee chaired by the Leader of the Opposition, who had the power to call any expert throughout the course of this to make sure to test information, test evidence, and be reassured. And I think that was very good for people as well, to see that the opposition had a role to play, to even during a time when Parliament was suspended, to keep the government in check in terms of the accuracy and quality of the information being provided. We were able to set up, in small country so we could do it, but a QR code scheme, so and rules about scanning. So if you, this is really after the lockdown, but if you go into premises, it's still a requirement today, although voluntary compliance at the moment. If you go into premises, you scan a QR code, it logs where you've been, and if you are then, if there is an outbreak and you potentially have had contact or close contact with an infected person, then you can release the data on your phone to say where you've been, and contact tracers can get an idea about what has happened. We are partway through our vaccination program, so we brought up the Pfizer vaccine. We've done, we have about 700,000 odd people, about 450,000 odd people fully vaccinated, 700,000 people with their first vaccination. We're going through a sequencing process, so starting with the most vulnerable, older people and what have you, and we are then sort of go down the age bands and what have you. At the end of this month, we will step up the rollout much more significantly, and we've been gearing up for that, so that's all underway. And the final slide there just shows some graphs and data about exactly where we've gone. We haven't had a community case since February anyway. So far, we did it after the major lockdown in March and April. We had about 3 outbreaks, but we haven't had any since February this year. Our borders are still closed, except they were open to Australia. We've had to suspend that because Australia is now having a major problem. We're open to the Cook Islands and a couple of other of the Pacific Islands, but otherwise the border is closed, and anybody other than citizens and residents of the country need an exemption to cross the border, which we do for a range of reasons. So that's sort of the New Zealand experience. We feel very fortunate. We have got to where we've got to. Confidence is high, and people are on this issue on pretty good spirits. So thank you very much.
Wonderful, thank you, Andrew. That's absolutely fascinating. Thank you. I do have a few questions that have been put through our Q&A function. So can we start with what has been the impact of the wellbeing budget?
Oh yeah, I think we basically sort of cut loose, and we invested heavily, obviously, in the wage subsidy. We also invested in a range of infrastructure projects to provide some stimulus to the economy. Obviously, we invested more heavily in the health system, funded the development of basically a new immunisation register, so that we could, as the vaccination program is rolling out, we could do that, and that'll be a platform to other health initiatives in the future as well, and obviously funding the vaccine. So the vaccine is free to, and it's not just citizens and residents, it's anybody who is in the country, even those whose visas have expired or who are here otherwise unlawfully, they will qualify for a vaccination. Yeah, we borrowed heavily for that. The impact on the economy hasn't been as severe as was predicted. And so, as I say, we've ended up in better shape, and it's now acknowledged that the support we've given business, there are a number of other initiatives too. We introduced state-backed low interest loans and what have you to tide businesses over. It's now acknowledged that all those initiatives really have kept many businesses intact and able to pick up and get trading again without too much long-term disruption.
Fantastic, thank you. And leading on from that, what do you think the main challenges that New Zealanders has faced, and how were these addressed?
I think that we are a country that has been dependent in some of our core economic sectors on overseas labour, and so as people returned home and we'd closed the borders, there's been an effort to fill gaps. We did, one of the other investments was in more training, more domestic training our domestic workforce. In the health sector in particular, we've always been heavily reliant on overseas graduates and overseas trained medical professionals. When you look at the number of people who, non-residents and non-citizens who've crossed the border, about 17,000 of them, about 45% are health workers, because that has been the top priority. So I think the labour market has been really tested in this. It has exposed a number of things about that, and about actually the extent to which some New Zealand residents and citizens had been shut out of the labour market before now. So there has been a bit of an opportunity for us to work on getting those who've been marginalised in the labour market to actually now get access to it, and get access to training, and get access to work. And that's starting to pay dividends as well, of course.
And just thinking into your presentation, what do you think are the main features that could potentially be transferred to other places around the world, but also to future pandemics?
I think the I think that the all of government response was critical, and we did, the heads of the public service right across the public service. Many of them actually just took on other roles to help with the coordination and the leadership. I think the very clear communication and communicating in advance so that people sort of had an idea about what to expect, so nothing was a surprise. And I think being open and honest about the risks and the threats too. Our Prime Minister, Jacinda Ardern, is a highly effective communicator and has a real sense about what information people are looking for at the time. She anticipated that. She did an excellent, she was quite a few nights doing Facebook Live sessions, usually as she's putting her daughter to bed, and just, I think, demonstrated that for her, the challenges were the same as everybody else. She had, she was part of a household, and they had to take the same precautions as everybody else. And I think people appreciated that understanding that she was affected just like everybody else, and was not afraid to say, what was going right, what was going wrong. And when things did go wrong, we stepped up and said that. We didn't try to defend the indefensible. We had, like most countries, our medical fraternity, there are plenty of public commentators on it. We have plenty of commentary, plenty of feedback, plenty of input as we develop strategies. Many of them were kind of embraced, if you like, to be part of the ideas machine about what we should do. So I think it is that being open to that public input and communicating clearly and effectively.
Great, thank you. And thinking about prevention, what do you think some of the broader lessons are going forward, and what do you think needs to happen now in a post-pandemic recovery?
Yeah, I mean, this is the challenging question as the world thinks about opening its borders and what have you. I think, obviously, completing the various vaccination campaigns, and that's right across the world, and that's the rich world has a job to do to support low-income economies and support those populations. And then I think it is that thing, as I think most countries discovered too, even if we like to think of ourselves as a more egalitarian country, we know there are people who are struggling to get access to health services. So part of the challenge we've got at the moment, myself as Health Minister, in terms of our health system, is making sure that we sort of don't repeat the mistakes of the past, and that we do make sure that health services are easily accessible, not just largely through geographical accessibility, that towns and communities have access to good quality healthcare, better use of technology. So telehealth, we've kind of really built a whole telehealth industry to an extent we never had before, so that you can do that through phone or whatever, get instant access to instant interim advice, even if you might take a little while to see a health professional. So I think making sure those things are in place, that health infrastructure is in place. Yeah, I think that those are the important things.
Great, thank you. And what are your plans to create a national health service in New Zealand?
Yeah, so I mean, the way our health system is structured, we have 20 health boards who are according to their statutes, independent entities. What we saw was, and we have seen for some time, even before the pandemic, is that there's just been this growing lack of coordination and cohesion across our health services. So when we do need to do a nationwide health initiative, it has, before the pandemic, it has been a struggle. The pandemic really kind of crystallized a lot of things, and people did kind of make things work, but kind of made things work against what the structure is kind of been set up to do. So as a consequence of that, and following a review that predated the pandemic, we made the decision to collapse all our 20 district health boards into one single nationwide entity, and so that we run our hospital network as a nationwide network, not as a network of 20 independents negotiating different policies 20 different ways each time. So that work is underway, and we have a target date of 1 July, literally 1 year from now, for that to be up and running.
Thank you. And were there communication strategies or channels that you found particularly effective in reaching more vulnerable populations and Indigenous communities in promoting hygiene measures?
Yeah, well, I mean, free-to-air television was still the most effective means. That everybody stopped to watch that. We had messages going out on a whole range of different channels. Social media was effective for some. For some of our more remote communities and our Indigenous communities, actually, and for Māori, face-to-face is a vital part of their kind of cultural value. So they just got around and saw each other and saw people. And the younger folks, younger adults, they went and visited the elderly in their homes to make sure that they were supported and secure. And some of the tribal organisations and tribal authorities, look, they just swung into action and provided food parcels and transport where that was needed, but basically just care for the more vulnerable members of their communities. They got their communication networks going, and it was very effective. And that's the amazing thing, is just getting around just what people knew and how articulate people were about the risk of this bug and what the precautions they had to take to keep them, their families and their communities safe, and a high degree of acceptance of that.
Wonderful, thank you. And just aware that you'll need to leave us in a few minutes, but just one further question for you. To what extent do you think ageism has had an impact on the delivery of services to older people in New Zealand?
Yeah, it's interesting. I mean, we know that, and like most countries, there were dreadful outbreaks in aged residential care facilities, and that's where most of our fatalities were, at that sort of level. So there was very early awareness that looking after our elderly was important. And we did that, but we also couldn't use that as an excuse to deprive them of opportunities to live a good and healthy life as well. So we had to achieve that, but we had to understand that there was a real risk for the elderly and make sure that the precautions we took were effective for them. And past the initial kind of outbreaks, most of our fatalities were in the early part of the pandemic, and we've been blessed not to have had any further since.
Wonderful, thank you. Andrew, it's been fantastic having you here. Thank you so much for your time. We really appreciate it. And we do understand if you need to leave at any time. But thank you so much for taking part today.
Yeah, thank you very much. I'm just sorry my video wasn't working, but anyway, I've been able to see you all, so thank you.
Yeah, we saw a picture of you on the slide.
All right, good evening.
Thanks then, bye. Great, now we're going to move on to Professor Chen Wen-sen, Shen from the Department of Business Administration at National Central University in Taiwan. Professor Shen also serves as the director of the UNIS Social Business Centre, the director of the Centre for Media and Social Impact, and division director of the University Social Responsibility Office at the NCU. So I'm just going to pass over now to you.
Hi, this is Mark Shen, and I would like to share the experience in Taiwan. Maybe something good, something maybe we're still learning, I think, but I think this is a platform we share with each other. So could you turn to the next slide? Yes, as you can see, this is the, I think probably you are familiar with the picture on the right side. It's a Taipei 101. So as you can see, we have a small character say Taiwan can't help. Why Taiwan can't help? Because I think probably, I don't know whether you know or not, because since last April to last December, we have no cases, no confirmed cases in Taiwan. So as you can see on the left side of the slide, we have, this is the iconic hotel in Taipei. It's a Grand Hotel in Taipei. So when we have 0 case, the Grand Hotel have a light show 0. So we have this kind of 0 for, I think, almost 9 or 10 months. So when we see the news about people, other countries suffering about the outbreak of COVID-19, but in Taipei, it's more like we are living in a parallel world. We still watch movies, we still go to a restaurant, we still attend a concert, we still see baseball game. So everything just like normal. And many professors around the world also ask me, now we use remote teaching. How about in Taiwan? I say, we still need to go to school, right? We still teach in class. We don't have remote teaching. Students have to go to university. Students have to go to schools. And the people still go to work as usual, okay? So I think that's the first stage. I think because Taiwan is very close to China, the epicenter of the, COVID-19 actually from China. So how can Taiwan, still have so, I have to say, unbelievable performance in the first few months? I think maybe I can, based on my observation, maybe I can identify some key factor, maybe that contribute this kind of, I think, unbelievable performance. Next slide, please. So I think Taiwan, follow most of the approach, in other countries. But I think we have Taiwanese, we have our own culture. So I think the culture is we feel comfortable about wearing mask. Okay, so the government actually asks the public, they have to wear mask when they take the public transportation. Okay, and in the meantime, we also look out, we need a sufficient supplies, for mask. So the government just asks the manufacturing plant in Taiwan, they don't allow the mask to be exported. All of the mask they manufactured should be sold in Taiwan. So at the beginning, each citizen, they can buy 10 masks within 2 weeks. Okay, so which means you can, during the working day, you can wear 1 mask 1 day. Okay, and it's mandatory if you take the public transportation, you have to wear a mask. Okay, so I think it's and the people feel very comfortable, wearing mask, because we have SARS before, so people are scared. People are scared of this kind of situation. So and if you don't follow the protocol, then you'll be fined. Okay, and the fine is it's more than 300 USD. So it's much. Okay. So second thing is about the government acts every main building. They have to provide some kind of a temperature monitor. Okay, so when people enter the building, they have to check their temperature to see whether they have fever. Okay, and the meantime also provide hand sanitizer in all of the public areas. So people, when they enter a building, they can use the hand sanitizer. So in the meantime, also check their temperature. I think that's very important to to protect, to see which person may have the potential to be the COVID-19 infection. Certainly, I think we control the border carefully. So when we know China has this kind of outbreak, because it's very close to Taiwan, we have many trade, we have many business between Taiwan and China. So we have to control the border very carefully. So at the beginning, when we know there's outbreak in Wuhan, China, then we mandate we need to have 14-day quarantine for all inbound travelers. So I think this is also very important, to control the border, So I think probably that's what I can conclude is probably that's the potential key reason, we have a very successful performance in the first few months. I think before 2021, everything here in Taiwan just like a normal life. Okay, we still also go to night market with, as I mentioned, we also watch baseball games. You can go outside, but when you take public transportation, you have to wear mask. That's the key difference. Okay, so maybe can you turn to the next slide? So as you can see, as I mentioned, when you enter a building, someone will check your temperature. Maybe manual, or maybe or some building also have a machine to check your temperature. So if you have fever, then you are not allowed to enter the building, and you also have to leave your records, and the building will call the hospital and call the local agency, to see whether you have infection or not. And in the meantime, almost in every main building, they also provide a hand sanitizer. You have to wash your hand before you enter the building. I think so people actually follow the protocol very well. Okay. So next slide. But this is the statistic data, as you can see. Before 2021, everything looked very mild. So as you can see, the red line means confirmed cases. So as you can see, before May, I think we are almost close only about, I remember only about 1,000 cases for the last 1.5 years. But since May 13, as you can see, we have a major surge. So we think 1 month, we surge from 1,000 cases to now, as you can see, we have around 15,000 cases within 1 month. So what happened? What happened to have this kind of surge? Okay. So I think after almost 18 months of nearly blessed success of keeping the COVID-19 at bay, so we also have probably the world record, the longest streak of case-free days. So, but all of a sudden, Taiwan has its first major COVID-19 surge in mid-May. So, what happened? So the outbreak likely began after splitting over from cargo plane cruise. We have flight between Taiwan and the UK actually. So we still have cargo flights between UK and Taiwan. So the outbreak likely from the cargo plane cruise between UK and Taiwan. So however, the bulk of surge has been tracked back to two major sources. One is a local Lions Club international gathering. Another one is a tea house in the red light district of Taipei's Wanhua neighborhood. And all of these two major sources all linked to the cargo plane cruise. Okay, so the cargo plane crews are infected and then disputed to the local Lions Club International Gathering and also the red light district of Taipei. Okay, and why cargo plane crews? Actually, that's supposed to stay in hospital in a quarantine hotel for 14 days, right? But in early April, the government somehow eased the protocol. They're supposed to stay in hotel for at least 5 days, but they lack the adherence to only about 3 days. Okay, so So I think Taiwan's current community outbreak began in April with cargo plane crews actually from the Novotel hotel near the international airport. Okay, because all the pilot groups, they have to stay in the hotel for 5 days. But in early April, the government lowered the quarantine requirement for non-vaccinated flight crew from 5 days to just 3 days. So some of the crew members actually they are affected. They were infected. But unfortunately, after 3 days they can go out. Okay, so I think this is the source of the outbreak. This is the source of the outbreak. And in the meantime, the hotel also violated the COVID-19 rule by housing quarantined flight crew and the non-quarantined guests in the same building. Okay, so as you can see, at least 29 cases actually are linked to the Novotel cluster, including the hotel staff. And the government also identified the case in Novotel cluster, the Lions Club cluster, and the cluster of the case in the Wanhua Red Light District. They were all infected with the same strain of coronavirus, which means they have the common source. Okay. So because of this outbreak, so as you can see, we have a big surge since mid-May. Okay. Can you show the next slide? So as you can see, in midday, we have a big surge. This is the confirmed case, the daily confirmed case, okay? But the maximum of the daily confirmed case actually only, compared to our country, I think we are still relatively low. The maximum case is about 500, okay? But after days of control, now in the past few days, the confirmed case lowered to only about 50 cases, only about 50 cases. But so far, we have problem to get vaccine, okay? So far, the vaccine rate is still very low. So I have to say, in Taiwan, actually, we don't count on vaccine. Actually, we count on protocol, strict protocol. And the citizens have to follow the protocol. Otherwise, they will be fined seriously, okay? So I think that's one of the key difference between Taiwan and the other countries. The citizens follow the protocol seriously, okay? And can you show the next slide? Okay, so like New Zealand, we also have, so after the outbreak in mid-May, we have a new system. People have to scan the QR code with their mobile phone when they enter a store, enter any building, okay? So the QR code will send the location, actually they fit it. So the government has a big data, you know, to know what kind of, which place everyone have been fitted, okay, after mid-May, okay? So if we have some confirmed case in a store, so the government will send text message to all of them, say, you've been to a place, actually they have a confirmed case. So we probably have to be careful. You have to be careful. So we have some kind of this big data analysis to collect all the fitted place every citizen has been. So you might ask the question, does every citizen follow the protocol seriously? I have to say yes, because if you enter a store, the store staff will ask you whether you scan the QR code or not. You have to, the staff will double check your mobile phone to see whether you scan the QR code or not. Okay. So if you don't scan the QR code, you are not allowed to enter the store. Okay. So this is what we done after mid-May. Okay. And after mid-May, before we wear masks only when you take the public transportation. but now you have to wear mask when you go outside. Okay, and we don't have lockdown, but after mid-May, university use remote teaching. Okay, and some of the company they work from home, and so you are not allowed to eat in restaurant. Okay, so I think it's more like a semi lockdown in Taiwan after mid-May. So we have to control the situation seriously. Okay, next slide, please. So now when you enter a public transportation, we check your monitor. So we have a temperature video to check everyone's temperature. If you are your temperature higher than 37 degree, then you will be called to check your temperature again to see whether you are potential risk. And as you can see on the right side, we almost in every building we have automatic temperature detector. Okay, you just put your head in front of the machine, so we'll check your temperature automatically. And as you can see in the bottom, they also have the hand sanitizer. So when you check your temperature, you can also wash your hand. Okay, I think that's very convenient. I think this is one thing I think you can see almost in every building in Taiwan. Okay. Next slide. Okay, so so what I say is the key difference between Taiwan and other countries is I think didn't follow the protocol seriously because we have experience of SARS, and so people wear masks and also scan the QR code to let the government know whether they have been okay, and also they wash your hand and we check the temperature carefully. So I think probably that's the key reason. Even we don't have enough vaccine, we can still lower the case within 1 month from 500 cases to 50 cases only within 1 month. Okay, but we are struggling because of the political issue, because there are some political issue in Taiwan and China. So we have some difficulty to get vaccine. But I think if we can follow protocol strictly, I think it's still possible to control the pandemic successfully. I think that's also a good reference to some other developing country if they don't have enough resource, to get vaccine. Okay, so that's my presentation. Okay, thank you for listening.
Thank you, that's wonderful. We're going to move on to some questions. So, I mean, that was particularly interesting hearing what you were saying about the culture of taking the protocol seriously. So you talked a little bit about SARS. There's a question here about what do you think Taiwan learned from SARS that was then used in the pandemic?
Okay, I think SARS, we lost about 100 people, okay, but only 1 month, okay, and the SARS disappeared all of a sudden. But based on this experience, so the medical care system, we prepare, we design, so we have so-called drills have been held periodically across Taiwan since the SARS epidemic. So in addition to regular review for infection control, all this auditing must be completed under the supervision of the infection control expert. So which means drill will be held regularly, periodically in medical care system, okay, to prepare this kind of situation. So all this auditing, so every 4 years, all hospitals are required to officially accredited by the Joint Commission of Taiwan, okay, to ensure that all necessary infection control personnel, equipment, and the reserve stock are in position. So therefore, when the government make the announcement about the outbreak of COVID-19 last year, so the hospital were able to activate immediately measurements such as triage, quick isolation, also strictly control crowd flow, and medical task force, and also epidemic prevention materials to maintain normal operation of the medical care system. Because we are afraid when there are so many people are infected, the medical care system have to be prepared very well, okay? So similar this integration in the medical system that happened to other countries has never occurred in Taiwan. So I think the medical care system prepared very well. I think after we have the SARS situation a few years ago. That's what I think. Mm-hmm.
Wonderful, thank you. Just one more question. After the next two presentations, that we'll have some more wider questions. But what do you think has worked well that could be applied to other countries?
Can you say the question again?
Yeah, what do you think has worked well in Taiwan that could be applied to other countries? So what do you think has been particularly successful that you think other countries could replicate?
Oh. Can be replicated? I have to say, this is interesting question, I think, because I think different countries have different culture. So I have to say, have a good citizen behavior is very important to prevent the outbreak of the pandemic. So in Taiwan, I think the government defined the protocol, and the citizens follow the protocol. So I think I don't know whether other country can follow this kind of rule. So maybe other Asian countries, if they have similar culture in Taiwan, so they can probably follow the like Japan, they can also follow the situation, the example in Taiwan, and I think that can also reduce the number of infection. That's what I think. Mm-hmm.
I muted myself, but never mind. It always happens. Thank you for that. We do have a few more questions, but I think they're sort of more directed to both you and the next speaker. So I'll come back to those at the end. So we're going to move on to Professor Itamar Grotto, who is the former Director of Public Health in Israel. In his capacities in Israel Ministry of Health, he led major changes in preventative services, including the establishment of the Israel Nation Immunization Registry and inclusion of 9 new vaccines in the Israeli public vaccination schedule. During the COVID-19 outbreak in Israel, Professor Grotto took a major role in the development of national strategy and led the integrative and operative aspects of the emergency response of the Israeli government. So I'm going to pass over now to Professor Grotto. Thank you for joining us.
Well, good morning and hello, London from Jerusalem. Unfortunately, I won't be able to use my camera, but you have my slides, so I will go briefly around them, and I will, of course, concentrate on the vaccination campaign, but also other lessons that were learned during the pandemic. So let's go to the next slide. I'll start with the vaccination. We had four principal things that we were thought very important. First of all, is the issue of safety. There were a lot of worries about the population about the safety. So this was then before the vaccine was approved, and after we did the post-marketing surveillance with excellent results regarding safety and effectiveness. Simple, and I will talk about it later. Flexible, and also very important, accessible. We wanted to make it as accessible as possible and allow the citizens to come to almost any place to get the vaccine. Although the operation itself was managed by the Ministry of Health, but the operators were the Israeli Health Maintenance Organization. We have four of them, all of them are public, and people are entitled to the National Health Insurance law, so they are have to be a member of one of these HMOs. Next slide, please. A little bit about the current situation of COVID in Israel. About 9% of the population were identified as PCR positive. This is the estimated infection rate. Of course, we know there are a lot of infections which were not identified. 6,000, about 6,000 fatalities. Currently, we have only 22 severe cases. In the peak of the pandemic, we were at about 1,200. It's a different number. And the peak daily capacity of PCR tests were 120,000. And of course, the main aim of the vaccination campaign was for the reduce all the restrictions that were taken during the previous episode of the pandemic. Next slide, please. Current status of vaccination, we have 90% coverage of the 50+ age group. This was achieved very early due to very high compliance of the public as well as accessibility of the vaccine. 5.5 billion are vaccinated. Just about 3 weeks ago, we started vaccinating children aged 12 to 16. It was as recently, the first compliance wasn't so high, but now when we have a small outbreak of the Delta variant, and also a lot of children are also coming to the vaccine. Next slide. If to go into the key principles of the vaccination campaign, so the first thing was as fast as possible by the HMOs, as I mentioned. They are the one who give the regular services, so we believe that they should also give the, of course, the emergency situation. The prioritization was very simple. It was according to age. It started with 60+ and then medical staff, and then reduced very rapidly because we had a good supply of the vaccine and a good operation. So we were able to allow to reduce the age by 10 years almost every week. And now, of course, everybody 12+ is vaccinated. We also offer people who were sick and want to get the vaccine, they can have another dose. It's not a must. It's not obligatory, but some people need it, for example, for travel abroad and other purposes. And of course, the main fight is the fake news to encourage the vaccine compliance. A lot of activity, mostly in the social networks. Next slide. So a little bit, the risk communication were very challenging. We had so-called new vaccine with emergency authorization. We were the first country to operate a mass vaccination campaign on the country level. So people trying to say, okay, we're doing a clinical trial and it's not a real vaccination campaign. Of course, this was, we talked about it with the Ministry of Health. We have the general vaccine as hesitancy among the population. There were some other COVID-19 specific implications of the level of trust between the governments and the public. Also in Israel, there were some mistrust during the event, and this was also problematic. And then, of course, the epidemic of the fake news, mainly in the social networks, as I mentioned before. Next slide, please. We used a lot of technology during the COVID-19 outbreak, not only for the vaccination campaign. These are some examples. For example, we launched the Shield application, which is actually application can can involve, if you were exposed to the patient. It was operative in the beginning, but then people were trying not to report because they thought it maybe have to get their friends into quarantine. So it was more complicated, but we used a lot of risk communication in this area. We have the Corona app, which includes all the data regarding different restrictions as well as different status of in Israel. Also, we did remote screening for concerned patients to give them personal guidelines using chatbot and WhatsApp bots that would allow the patients also to talk with us and with the call center of the Israeli Ministry of Health. Next slide. I think it's one of the main important issues that was very helped us very much with the successful immunization campaign was the health information exchange system that we already have in Israel. This is a slide not from the pandemic, but from we have a system that connects all the hospitals, the IDF, the HMOs, all of them is connected to one. They can get all the data from each other. It's not a database, it's something that can be connected once the patient comes to get treatment, then you can get into his medical file, but when he goes, it disappears. So it's not a database that with the privacy issue and all the security issues. And we also have, and this we can say in the next slide, please, what we call the immunization registry. This is a paper that was published just before the COVID-19 outbreak. Describing the immunization registry, which is a national immunization registry, which no matter who is giving the vaccine, either the HMOs, Ministry of Health itself, hospitals, IDF, private providers, all of it is now being registered in one national registry, which allowed us two important things. One of them is to monitor the compliance to the vaccine, see if there are places for interventions. This is one thing, and the other thing is that we, of course, could use this database to fit it also to cross check it with the COVID patients database, which is also one database to estimate the national immune efficacy and effectiveness, which was very important both to Israel and the world. Next slide. So, as I mentioned, the safety and effectiveness was based on passive and active surveillance. We also monitored the effectiveness by the health registry, by the immunization registry, and also the HMO themselves used this data. We gave them the data about the vaccines, and they used it also to calculate the efficacy among their patients. And of course, this was all very transparent and were published. Both the side effects were published on a weekly report, as well as the effectiveness, both in the public reports and scientific articles that were issued very soon after we had the first data that was available. Next slide. Here you can see, in this slide, you can see an example from February 13th. This is just in the, not in the end, but in the middle of the campaign. You see that we collect the very good effectiveness, both after the first dose and then a little bit higher after the second dose. You can see the number with the prevention of hospitalization of between 96 to 99%, very good. At that time, I must say that the most prevalent variant was the UK, what we call the UK variant, was the most prevalent. Now we think the Delta variant, and we don't have yet the results regarding the effectiveness because there are too small number of cases. Next slide, please. And the lessons learned. So the call center was very important both for the public and professional. The issue of logistics were very important. Just one example is to need to create smaller cases for distribution because the Pfizer vaccine comes in 96 vaccines in one package, and we had to make it into small packaging in a GMP facility. We were also training EMT and paramedics, which are not allowed on a regular basis to vaccinate in Israel, only nurses and physicians doing that. So now they are also trained and also helped in adding to the surge capacity of the vaccination. Next slide. As I was talking about the technological tools, mainly the national immunization registry, but other applications that were used during the pandemic. I discussed the issue of monitoring effectiveness and side effect tracking, which is very important in order to convince the public that it's going good and it's safe and effective. The professionals were the one who led to the risk, most of the risk communications, politicians or other journalists. So it was very important that the professionals would be the presenters, both in campaigns and also in different media routes. And finally, the documentation, the vaccine certificate, which everybody can get both from the internet as well as from the application, which is the Green Pass application, which will be my last slide. So this is actually how it looks like, the Green Pass program. This is something that you can get once you've got 2 vaccines and a week passes from the second dose. So everybody who was vaccinated could download this application. And it was used during a period of about a month to do the Green Pass program, which means that some of the places like this open, like closed restaurants, other events, weddings, theater, sports events, etc. We use the Green Pass problem, which allowed only those who present the Green Pass to enter. Now, after the situation is much better in Israel, and we don't have so many cases, and we see a decrease in number of cases. So we stop now. Everybody is open in Israel. We don't have to go with the Green Pass, but this is one of the tools that we have in case that we see now a new wave that is related to Delta variant. Thank you very much, and I'm here to answer some questions. Thank you.
Wonderful. Thank you so much for that presentation. Very much appreciated. I have a couple of questions from the group. What do you think, thinking about your lessons learned, could be applied elsewhere in other countries?
Well, I think the thing that applicable, we can first look at the vaccine campaign that was delivered by HMO. I think the very quick organizations as well as the vaccination registry was very important in that step. And also we had to take some logistic chances, although it was not approved by Pfizer, for example. We could still did our own testing with the pharmaceutical department of the Ministry of Health. And then after we did the test, we realized that it's possible also to make small quantities to reach for very far places in order to be as accessible as possible. So these 2 lessons are related to the campaign. I can also tell you that the Green Pass program could be of help if it is working for sometimes during the peak of the event. You don't have to use it all the time, but during the peak of the event, it was very helpful both to protect the people as well as to convince people to get the vaccine, because the young people wanted to get the Green Pass in order to get into all restaurants, bars, sports events, etc. And maybe I'll go back later to the previous phases before we had the vaccine. I think the most important thing that we did was besides the regular lockdowns, social distancing, etc., was to concentrate a lot on testing, targeted testing in places where there were red zones or red cities, where we work with the mayors, with the cities, with the citizens to increase the number of tests in order to stop the transmission cycles within these areas. So I think these are the main things that I can take. And of course, one thing very simple, but the use of the mask. The mask was very helpful during all the pandemic, and now it's still being used in Israel in those places.
Great, thank you. And what do you think some of the broader lessons are for preventative services going forward?
So the short-term lessons would be talking about emergency preparedness at all and in general, and then of course giving the people some kind of what we use is some kind of a reserve unit. It means that something that can become big and small depending on the event. This will include laboratory capacity as well as epidemiological investigators and all this. So we have to have some kind of a reserve unit, and this is one of the lessons. I hope we will develop this after the event will be over. And other thing, if we cannot change the infrastructure of the health systems because many things are dependable on that, we have to see how we can use combine both technologies to allow to different providers if they all have access to the same database and all of the people are talking on the same data. And it's, first of all, it does not confuse the public. It took us time but then everybody was talking on the same data and everybody was connected, and we had the central command center, which actually was very active, and this is also very important to manage such kind of an event. With all the relevant government ministries, the police, etc. This was also
fantastic. I think we have time for one more quick question. So how far do you think political culture is important in the effectiveness of handling COVID?
I didn't understand the question. Sorry, I didn't hear well.
Sorry. So how to what extent do you think political culture is important or has been important in handling the pandemic?
Well, I think culture is very important. I think we see that we saw that in Israel. Because we have different cultures in Israel. We have different cultures in Israel, both the ultra-Orthodox, the Arab population, and the Jewish population, and we saw the difference in the culture, both in the compliance with the regulations as well as compliance with the vaccines. In each of these cultures, we had to work with different culture leaders to convince the vaccine. For example, with the ultra-Orthodox, we had to work with the chief rabbis and chief leaders that once they would say they're saying go to vaccinate, then all the people go to get the vaccine. So this is, of course, very important. And I think the issue is culture is because when we wanted to get out, for example, from the from the first wave, and we thought that we will give some regulations, people use masks and things like that, social distancing, it did not work because people were not complying so much. They thought the COVID is over and did not comply. So this was an issue, and we see how different in the culture, and I believe this is also different, relevant. And of course, this is a different culture between, for example, Taiwan and Israel, very different culture, very different way to look at them. Also, the response should be different.
Thank you. So I think we're at the end of today's session. I could talk about it for so much longer. So, apologies, we haven't got through all of the questions. But I just wanted to reflect very quickly. Some fantastic presentations. I just wanted to say thank you to Professor Grotto, Professor Shen, and Andrew Little for their time today. Very busy people, so fantastic that you gave your time today. We heard about the importance of data sharing across healthcare providers, technological innovations, the importance of communications through call centres, through acting early, and having that trusted voice that people will listen to. We heard about citizenship and the importance of taking rules seriously, targeted testing and training to increase those who can administer vaccinations. Fantastic lessons, wonderful. This will really inform our prevention programme going forward. Again, I just wanted to say thank you to our speakers today and to everyone who's joined us. We're a minute over time. But thank you very much and enjoy the rest of your day.
Thank you very much.
Thank you. Thank you for the invitation. Thank you.